The following podcast is part of a certified educational activity titled Visual Exploration of the Evolving Role of Novel Oral SERDs, Other ER-Targeting Therapies, and Rational Combinations in ER-Positive HER2 MBC. Access the entire activity and complete the post-test at peerview.com/AQV860. Downloadable practice aids are also available.
Welcome to the PeerView in Motion activity titled Visual Exploration of the Evolving Role of Novel Oral SERDs and Other ER-Targeting Therapies and Rational Combinations in ER-Positive, HER2 Metastatic Breast Cancer. I'm Komal Javeri, a breast medical oncologist at Memorial Sloan Kettering Cancer Center in New York. Our goals for today's discussion are threefold. First, we'll augment our knowledge about the efficacy and safety of novel oral SERDs and other ER-targeting therapies and rational combinations in ER-positive, HER2 metastatic breast cancer. Second, we'll work on enhancing our understanding of the clinical and practical implications of the recent studies assessing new and emerging SERDs in ER-positive, HER2 metastatic breast cancer space. And last but not the least, we'll talk about how can we equip ourselves with skills in developing individualized treatment plans for our patients with this subtype, incorporating these novel endocrine therapies, including these oral SERDs and combinations. I'd like to thank METAvivor, who's our patient advocacy partner in this program. Really, METAvivor is an organization focused exclusively on stage 4 metastatic breast cancer, with a mission to improve the lives of people living with advanced breast cancer by funding research, advancing policies through advocacy, and facilitating a community of peer-to-peer support. We are very grateful to METAvivor for contributing insights from patients and their care partners as part of this program. Please access and use the supplemental resource compendium made available as a component of this program from METAvivor. So let's start talking about how do we envision new strategies for addressing the unmet needs in ER-positive, HER2 metastatic breast cancer. We know that under the selective pressure of therapies, there is tumor evolution. Now, certain tumors can retain dependency on ER activity, and there'll be others that will lose this ER dependence. Today's discussion will predominantly focus on patients where tumors retain the dependency on the estrogen receptor activity, and this is predominantly the AI-resistant or the aromatase inhibitor-resistant, yet ER-dependent tumors. For our loss of ER-dependent tumors, certainly there is a lot of lineage plasticity that we see, which leads to poor outcomes. But regardless, endocrine resistance certainly brings in this component of poor outcomes that we're trying to tackle in clinic. Combined with that, there is a lack of consensus for treatment selection and sequencing following disease progression after first-line therapy. So really a lot more work to be done, not only to understand the biology, but also to optimize sequencing. Now, when we talk about this ER-dependent tumor growth, we're referring to the acquiring of ESR1 mutations under the selective pressure of ESR1. Now, a study done at Memorial Sloan Kettering Cancer Center, amongst others, did look at various endocrine resistance mechanisms, the most prevalent of which was, in fact, this development of ESR1 mutations. And these ESR1 encodes the estrogen receptor alpha, which is an isoform of the estrogen receptor. In fact, when we think about these ESR1 mutations, we know that these are not detectable in primary tumors. And in the metastatic setting, prior to first-line therapy, the prevalence is also slightly low in the order of about 5%. However, after progression on first-line therapies in the metastatic setting, they become a lot more prevalent in the order of about 40 to 50%. Now, what happens is when this ESR1 mutation occurs, we do not require the ligand to bind to the estrogen receptor for its activity, But despite this ligand independence, there is a transcriptional network that is still being driven and is causing further activation of the ER pathway. So it's ligand independent, yet ER dependent tumor growth, which is why our research efforts have focused on identifying therapeutic agents that can not only tackle ESR1 wild type, but also particularly tackle ESR1 mutant tumors that have this ligand independent ER dependent growth. We further also want to do that because we know that while we have effective anti-estrogen strategies in clinics such as aromatase inhibitors, tamoxifen, and our SERD fulvestrant, these are challenged not only by pharmacological limitations and toxicity, but also adherence. For instance, we know the toxicity challenges we face with both aromatase inhibitors and with tamoxifen. With aromatase inhibitors specifically, we spoke about these emergence of ESR1 mutations, and tamoxifen acts like a weaker ER suppressive agent. When it comes to fulvestrant, while it has shown activity beyond progression on AI and tamoxifen in the metastatic setting, we know it is challenged by lack of oral bioavailability. It requires intramuscular administration for patients. The efficacy in clinic is dose dependent. However, we're not able to give a higher dose than 500 milligrams intramuscular injections. These injections we know can be burdensome and painful, requiring in-office administration for our patients. And more recent data sets have shown that the efficacy post-CDK4/6 inhibitor is rather modest in the order of about 2 to 3 months. Last but not the least, even within the different kinds of ESR1 mutations, fulvestrant has limited activity in certain ESR1 mutations, especially the Y537S mutations. And this is why there has been a lot of effort put in place to develop newer ER-targeted agents with the idea that we're trying to downregulate the estrogen receptor with an agent that has an optimal therapeutic index, an improved efficacy profile, and can overcome the current challenges that we just reviewed with our currently available agents. Now, tumor growth in the presence of ESR1 mutations can be tackled with, as I said, newer novel endocrine agents. One good example that has already now been approved for our patients are oral SERDs. And so similar to fulvestrant, these SERDs can downregulate the estrogen receptor signaling pathway. Not only can they degrade and serve as an ER antagonist, but can also tackle the downstream transcription activation that occurs. The only difference is that now this is an oral agent, unlike fulvestrant, which is intramuscular. Besides oral SERDs, there are other novel targeting agents. These include novel SERMs, such as lasofoxifene, which not only have activity similar to tamoxifen in wild type, but have also been able to show activity in ESR1 mutant types. We have SERDs, or complete estrogen receptor antagonists, which, unlike tamoxifen, that only focuses on AF1 binding domain, focuses on targeting both the activating function 1 and 2 binding domains, causing complete antagonism. We have palazestrant, which is a first-in-human SERM that is currently in late-phase development. And last but not the least, we have proteolysis targeting chimera or PROTAC, which not only target the estrogen receptor, but also target the E3 ligase and together cause ubiquitination and degradation of the estrogen receptor. And we have vepdegestrant, which is our first-in-human PROTAC, and we'll talk about the data from these drugs as well in this activity. So who should we be testing, and how do we identify these various biomarkers such that we can use these novel endocrine agents to our advantage and overcome the issues that we face in clinic and improve outcomes? Our current guidelines recommend that treatment choices be informed by prior treatments and by routine testing of current activating mutations in not only the PIK3CA, AKT, and PTEN genes, but also in ESR1. How do we test for these? Let's focus specifically on the example of ESR1 mutations for this. ESR1 mutations, as we said, emerge under the selective pressure of aromatase inhibitors in the metastatic setting. And these are generally subclonal mutations, which is why the most optimal way of identifying these mutations are, in fact, through ctDNA. And this is because if you go and test for a biopsy site, you might potentially miss the alterations, especially the ESR1 alterations, in the other biopsy sites. However, ctDNA can actually provide this opportunity where, despite different metastases developing different resistance mutations, these are spilling in the blood and can be captured very appropriately in the plasma. And so, unlike PIK3CA, which is a truncal clonal alteration that can be detected in primary tumor, metastatic tumor, tissue, or plasma, it is better to evaluate and look for ESR1 alterations in ctDNA, where the prevalence can be as high as 40 to 50% in the second or third line setting. Now let's move on and talk about the key learnings from the data on oral SERDs and various combinations. Now, first of all, the very first signal that we have been able to appreciate from the ongoing trials and trials that have been completed for oral SERDs is that there is monotherapy activity compared to standard of care endocrine therapy across these randomized trials, especially in patients whose tumors harbor ESR1 mutations. So this table is summarizing data from the EMERALD trial, SERENA-2 with camizestrant, AMEERA-3 with amcenestrant, and ACCELERA trial with giredestrant. And the idea is not to do any cross-trial comparisons here. These are different trials, some phase 2, some phase 3s, with varying patient populations that were enrolled. However, whether it was a positive study, such as in EMERALD and SERENA-2, or a negative outcome, as in AMEERA-3 and ACCELERA, the one common signal that borne out of these trials was that there was activity certainly seen with these drugs compared to standard of care in ESR1 mutant tumors. Those were statistically significant in the phase 3 EMERALD trial, leading to the FDA approval of elacestrant, was certainly a positive signal in SERENA-2 with camizestrant, which was a phase 2 trial. With ACCELERA and AMEERA, which were negative readouts, there was still a numerical benefit that was still appreciated, especially when you looked at ESR1 mutant tumors. Again, varying patient populations, but a common signal. However, another learning that we've been able to appreciate from these monotherapy efforts has been that regardless of whether the patients were enrolled to the standard of care or to this novel endocrine arm, 40% had very early progression with monotherapy. And for those who did derive benefit, the benefit was limited to nearly less than 6 months, really highlighting or underscoring the need for rational combinations to further improve outcomes of our patients with novel combinations. In that context, why don't we take a look at data from the phase 3 EMBER-3 trial that enrolled men and pre- or postmenopausal women with ER-positive, HER2-negative advanced breast cancer who had recurrence on or within 12 months of completion of an aromatase inhibitor with or without CDK4/6 inhibitor in the adjuvant setting, or had prior therapy for advanced breast cancer with progression on first-line therapy, again with an aromatase inhibitor with or without CDK4/6 inhibitor, and no other treatment for advanced disease. 874 patients were enrolled to one of the 3 arms, Arm A being imlunestrant alone, administered at 400 milligrams orally daily. Arm B was standard of care endocrine therapy, and Arm C was added as a study amendment shortly after study had started accrual and evaluated the combination of imlunestrant plus abemaciclib with 3 primary endpoints, which were investigator-assessed PFS, comparing arms A and B, which is monotherapy arms, in patients with ESR1 mutations, or all patients, and last but not the least, Arm C, which is the combination arm, compared to imlunestrant alone in all patients. With respect to baseline demographics and disease characteristics, these were well balanced across the three arms. I'd like to highlight approximately 40% had ESR1 mutations at baseline. Approximately 40% had alterations in the PI3K-AKT or PTEN. About 2/3 of these patients had recent endocrine therapy in the advanced setting and a third in the adjuvant setting. Approximately 60% had received a prior CDK4/6 inhibitor. Understandably, and as expected, very few patients had adjuvant CDK4/6 inhibitor. Majority were in the metastatic setting. Here are the results for the primary endpoint looking at investigator-assessed PFS for imlunestrant alone compared to standard of care endocrine therapy in patients with ESR1 mutations. There was an improvement from 3.8 months in the control arm to 5.5 months in the imlunestrant arm, translating to a 38% reduction in the risk of progression or death favoring imlunestrant. Even at the 12-month time point, more than 3 times patients were progression-free in the imlunestrant alone arm compared to standard of care therapy. Looking at investigator-assessed PFS of imlunestrant versus standard of care therapy in all patients, there was no statistically significant difference, with median PFS of 5.6 and 5.5 months in the imlunestrant and standard of care endocrine therapy arms respectively, with a hazard ratio of 0.87. Since the imlunestrant alone arm in ESR1 mutant tumors was positive, arm C then was compared to arm A, and we for the first time see with a combination of imlunestrant plus abemaciclib, there was an improvement in median PFS from 5.5 months in the imlunestrant alone arm to 9.4 months for the combination, with a hazard ratio of 0.57. That is a 43% reduction in the risk of progression or death, which was statistically significant. Again, at the 12-month time point, nearly double the patients were progression-free in the combination arm compared to imlunestrant alone. Now, important subgroup analyses to focus on for this combination of imlunestrant abemaciclib compared to imlunestrant, specifically when we look at ESR1 mutant and wild-type tumors. We learned that monotherapy was only effective in ESR1 mutants. However, the activity of the combination was seen regardless of ESR1 mutation, specifically 11.1 months median PFS in those tumors with ESR1 mutations and 9.1 months in those that were ESR1 wild type. Now in clinic, certainly we utilize CDK4/6 inhibitor in the first-line metastatic setting. So it was important to evaluate 2 key subgroups. One, what was the activity for imlunestrant abemaciclib after prior CDK4/6 inhibitor therapy? And second, we also utilize agents targeting the PI3K pathway. And what does this combination of imlunestrant abemaciclib offer for PIK3 or PIK3 pathway mutant tumors? And reassuringly in this data set, what we saw is that despite 65%, which was majority, receiving prior CDK4/6 inhibitor, the combination of imlunestrant plus abemaciclib was beneficial, yielding a median PFS of 9.1 months compared to 3.7 months in those with prior CDK4/6 inhibitor therapy. The hazard ratio was consistent at 0.51. Similarly, when we looked at PI3K pathway mutant tumors as well, imlunestrant plus abemaciclib yielded a median PFS of 7.6 months compared to 3.8 months in the imlunestrant alone arm, again, hazard ratio of 0.61. Now, looking at the subgroup analysis of progression-free survival benefit by line of therapy, as you might recall, that the trial did allow patients who can progress on their adjuvant therapy with an AI with or without CDK, or on their first-line metastatic therapy, again, with AI with or without CDK. However, benefit was maintained regardless of line of therapy. In the small cohort of patients that received monotherapy imlunestrant in the first-line setting, median PFS was 11.1 months. In the standard of care was 5.7 with a hazard ratio of 0.48. In the second-line setting, as we see, it was 3.8 months in the standard of care arm compared to 5.5 months with imlunestrant, hazard ratio of 0.66. Similarly, subgroup analysis for the combination was also looked at by line of therapy. And in the first-line setting, the combination of imlunestrant plus abemaciclib yielded a median PFS of 14.4 months compared to 5.7 months in the control arm. And in the second line, as we heard, 9.1 versus 3.8. Turning on to safety and tolerability, the treatment with imlunestrant was very well tolerated with very low grades of fatigue, diarrhea, and nausea, which were all predominantly grade 1 and mostly single episodes. The grade 3 or higher toxicity was in fact 17% in the imlunestrant arm and 21% in the standard of care endocrine therapy arm. Importantly, dose reduction rates and discontinuation rates with monotherapy were very low at 2% and 4% respectively. Now, understandably, with the addition of abemaciclib to imlunestrant, there was a higher incidence of toxicity, especially diarrhea. However, again, this was low grade, predominantly grade 1. The dose reduction rates were about 39%, and discontinuation rate was again low despite the addition of abemaciclib at 6%. Now, these data are in line with what we had seen with abemaciclib and fulvestrant in Monarch 2 as well, with no drug-to-drug interaction seen in the phase 1 study with abemaciclib and imlunestrant, and that is what has translated into this lower discontinuation rates and low-grade toxicity for the combination. Importantly, no cardiac or ocular toxicity signal has been reported in the abemaciclib and imlunestrant arm or on the imlunestrant program thus far. And now, while efficacy and safety are important, equally important are quality of life data and how patients tolerate treatments in clinic. And we do have patient-reported outcomes available from the EMBER-3 trial. And what we learned was that the global health status and quality of life and functioning were maintained with imlunestrant plus abemaciclib despite increased patient-reported diarrhea and nausea vomiting. Both longitudinal and time to deterioration analyses of global health status and quality of life numerically favored imlunestrant compared to standard of care endocrine therapy in patients with ESR1 mutations, suggesting that imlunestrant delays deterioration of quality of life without meaningful increases in toxicity. An importance of injection site reactions as a clinically relevant adverse event for patients is also demonstrated in this analysis by high incidence in the order of 72% of patient-reported injection site reactions with fulvestrant, again highlighting what our patients appreciate in clinic. Now, while we have seen this monotherapy data with ESR1 mutant tumors with oral SERDs, and we've also seen this combination data for imlunestrant and abemaciclib in the second-line predominant setting, can we also utilize a strategy of utilizing these oral SERDs in combination with CDK4/6 and use them for molecular progression without radiological progression? And this was the strategy or the question that was being addressed by the phase 3 SERENA-6 trial, which has also reported. So the SERENA-6 trial focused on patients who are being treated in the first-line setting with standard of care aromatase inhibitors and CDK4/6 inhibitors. These patients were then screened with ctDNA analysis looking for ESR1 mutation emergence. For patients who then were found to have ESR1 mutations without radiological progression, these were randomized to switching to camizestrant and maintaining the same CDK4/6 inhibitor with a placebo for the aromatase inhibitor versus continuing the AI and the same CDK4/6 inhibitor with a placebo for camizestrant. With respect to baseline characteristics for these patients, 300 patients were randomized. So 3,000 was screened, 300 were randomized. And when we evaluated time to ESR1 mutation detection, the median time to develop these mutations was nearly 22 months. It is important to point out that the CDK4/6, it could have been any CDK4/6 inhibitor in the first-line setting. Palbociclib comprised about 75% of these patients. 15% were treated in the first line with ribociclib and maintained that with either the switch with camizestrant or continuing the same therapy with detection of ESR1, and a very small proportion, nearly 9%, were treated with abemaciclib. Here are the results for such a strategy and this approach in SERENA-6. The median PFS in the AI plus CDK4/6 continuation of therapy arm was 9.2 months. It was improved to 16 months in the camizestrant plus CDK4/6 treatment arm. The hazard ratio was 0.44, which was statistically significant. With respect to safety, there were no new necessarily safety signals beyond what we had expected for camizestrant alone. And all the additional toxicities that are reported are in line with what would have been expected with the addition of a CDK4/6 inhibitor, with the most common toxicity being neutropenia. In fact, with exposure time-adjusted incidence rates, when we evaluated these rates, when adjusted for exposure time, were similar between the treatment arms for neutropenia. There is an interesting signal that we see with camizestrant, which is photopsia, which is predominantly intermittent and low-grade, with very few, if any, high-grade events. In the SERENA-6 trial, 20% were reported to have photopsia. Additionally, very low grade of bradycardia that has been reported with this drug as well, with no high-grade bradycardia events, and specifically low-grade bradycardia, especially at the dose that is currently being utilized in this trial and other phase 3 programs with camizestrant, which is 75 milligrams. Last but not the least, a very interesting data set that was also reported out in the SERENA-6 study was to look at time to deterioration in global health status and quality of life. And as seen here, again, there is a statistically significant improvement in time to deterioration with 23 months in the camizestrant arm compared to 6.4 months in the AI CDK4/6 inhibitor arm with a hazard ratio of 0.53, which is meaningful. There are other combination trials in this space with oral SERDs, including combinations with agents targeting the PI3K, AKT, mTOR pathway. One such example is the ADELA trial, which is evaluating the combination of elacestrant plus everolimus versus elacestrant alone for a primary endpoint of blinded independent central review progression-free survival. And we also have the ongoing Pioneera trial, which is enrolling men and pre- or postmenopausal women with endocrine-resistant disease. So these are patients who have relapsed on prior adjuvant therapy. This is adjuvant therapy after more than 12 months of treatment or within 12 months of completion of their prior therapy and no other systemic treatment for locally advanced or metastatic disease. Patients are going to be randomized to giredestrant plus CDK4/6 inhibitor, and this could be any of the 3 CDK4/6 inhibitors compared to fulvestrant with CDK4/6 inhibitors, again for co-primary endpoints of progression-free survival by investigator assessment in ESR1 mutant population and the entire analysis population. We also have the EVERA trial. Again, this is evaluating giredestrant plus everolimus compared to physician choice endocrine therapy with everolimus for co-primary endpoints of progression-free survival by the investigator assessment in both intent to treat and ESR1 mutant patient population, and we hope to hear data from this trial hopefully later this year. Now, beyond the strategy of second line that we discussed, beyond the SERENA-6-like strategy, which is adapting based on molecular progression, we also have ongoing trials in the first-line space with head-to-head comparisons of SERD with CDK4/6 compared to AI with CDK4/6, which is the standard of care for our endocrine-sensitive patients. And two such efforts that are currently ongoing are Persevera with giredestrant and palbociclib compared to letrozole palbociclib, and Serena-4, which is camizestrant plus palbociclib versus anastrozole plus palbociclib, both with primary endpoints of progression-free survival that are currently ongoing. So it's yet to be determined what strategy might be the most optimal way of utilizing these agents. We spoke about the challenges with endocrine therapy and how adherence can be really impacted because of the toxicity issues, which is why these novel endocrine agents and oral SERDs are also very, very attractive, given that we're now utilizing them or studying them even for early stage breast cancer. And this table really summarizes all the research efforts in place, including upfront randomization with standard of care endocrine therapy, or even a strict switch strategy as is being evaluated in Cambria and EMBER-4 study, where patients would be treated with a standard of care endocrine therapy for 2 to 5 years and then be switched over to an oral SERD versus continuation of this endocrine therapy. We're also looking at ctDNA-based approaches, as in the treat ctDNA with elacestrant. So a lot of exciting efforts in this early stage with the idea of further improving adherence, compliance, which would translate into improved outcomes, hopefully, for our patients. The other endocrine agents that are also being evaluated beyond oral SERDs, again, are novel SERMs, such as lasofoxifene. We have the proteolysis targeting chimera, such as ARV-471 or vepdegestrant, and CERAN or complete estrogen receptor antagonists, such as palazestrant. And why don't we see the data that we now have available from the phase 3 trial, which is the VERITAC-2 study looking at vepdegestrant. Now, this trial focused on patients who've had no more than 2 lines of endocrine therapy, one of which had to be a CDK4/6 inhibitor, no prior chemotherapy or prior SERD, and the most recent endocrine therapy had to be for 6 months or longer. Patients were randomized 1:1 to receiving vepdegestrant administered at 200 milligrams orally daily versus standard of care dosing of fulvestrant for primary endpoints of progression-free survival by blinded independent central review in ESR1 mutant tumors and all patients. Here are the results for the primary endpoint. As we have seen with other monotherapy trials, again, a signal was seen in ESR1 mutant tumors. The control arm had a median PFS of 2.1 months with fulvestrant alone, which improved to 5 months in the vepdegestrant arm, a hazard ratio of 0.57, which was statistically significant. We did not see statistical significance in all patients. The median PFS was 3.6 in the fulvestrant arm and 3.7 in the vepdegestrant arm. Hazard ratio was 0.83. Again, when we're thinking about this investigator-assessed PFS, even in investigator-assessed PFS, the improvement was seen and the hazard ratio was significant in the ESR1 mutant cohort, improvement from 2.8 to 5.4 months, hazard ratio of 0.52. What about the safety with the vepdegestrant? This drug is also extremely well tolerated, as is reflected by the rate of grade 3 or higher toxicity, which was reported in 23% of the patients in the vepdegestrant arm compared to 18%, and extremely low dose discontinuation rates at 3% and dose reduction rates, which was 2%. One important side effect to be bearing in mind with vepdegestrant, which was a treatment emergent AE that was reported, was QT prolongation, reported in 10% in the vepdegestrant arm, 1% in the fulvestrant arm. However, in a small sub-study looking at QT intervals, about 88 patients, this was confirmed to be a mild increase of 11 milliseconds from baseline in QTCF, indicating no large QT prolonging effect. So really low-grade events of QT prolongation, which were not clinically impactful, and a mild increase of 11 milliseconds from baseline, which has been seen thus far. Other treatment emergent AEs of more than 10% in either group are shown on this table, most common being fatigue. Any grade fatigue reported in 27% in the vepdegestrant arm and 16% in the fulvestrant arm. And last, let's talk about how do we move towards updated standards of care and gear up to selecting and sequencing treatments using a new algorithm. Talking about the algorithm, when we think about in the first line setting, majority of our patients would be treated with an AI and a CDK4/6 inhibitor. However, what happens next is what is evolving dynamically as reviewed by the data that we have seen thus far in this space, including that upon radiological progression, certainly our treatment selection is biomarker based. We already have elacestrant approved for ESR1 mutant tumors. We have agents targeting the PI3K approved for tumors harboring PIK3CA mutations with alpelisib and those with PI3K, AKT, or PTEN with capivasertib. Certainly, EMBER-3 provided data and justification to utilize imlunestrant abemaciclib regardless of whether there is an ESR1 mutation or a PIK3CA mutation. And for our wild-type tumors, we have data sets justifying either monotherapy or the combinations with everolimus and fulvestrant, abemaciclib and fulvestrant based on the post-MONARCH data, and EMBER-3 imlunestrant plus abema. However, I have to highlight that imlunestrant abemaciclib is currently not approved. We also saw the SERENA-6 data to see if perhaps ctDNA-guided switch could be a strategy for camizestrant and continuing the same CDK4/6. Again, we have the data. We don't necessarily have the approval, but something to keep an eye on. In the patients who have had progression on an AI and are endocrine resistant, the first-line treatment, the backbone would be fulvestrant. Now, again, the EMBER-3 did have first-line patients where imlunestrant and abemaciclib, if available, could be utilized, or even imlunestrant alone, if available, could potentially be considered. However, majority of our patients will receive a CDK4/6 in the first line, and for endocrine resistant, it will be a SERD and not an AI. And again, for our PIK3 mutant tumors in the first line, we now have data from the INAVO 120 study evaluating the triplet of fulvestrant, INAVO, and palbociclib. The second line strategies, again, are biomarker-based, and treatment selection is based on the biomarker as reviewed for endocrine-sensitive patients. Beyond endocrine resistant tumors, for endocrine refractory disease, certainly we move on and start utilizing single-agent sequential chemotherapy and antibody-drug conjugates, which are now approved and available for patients in clinic. What is really, really important, however, when it comes to these novel endocrine agents that we've been discussing in this activity is what is a patient perspective and a preference when it comes to these oral agents? Do they really appreciate or would prefer these oral therapies? And accumulating evidence does suggest that that's the case, given the convenience, given the ability to receive these treatments at home, avoiding the discomfort or need to coming to office for receiving injections. And it does seem like patients do have certain other relevant factors and reasons to be able to justify wanting these oral therapies, as also reflected in the patient-reported outcomes. And here is a representation of the adverse event profiles of oral SERDs. While these oral SERDs have similarities in terms of their activity that we've been able to appreciate in ESR1 mutants, there are some slight differences in their toxicity profile. For instance, with elacestrant, we see some low-grade nausea and fatigue that our patients appreciate in clinic. Very few patients would require any dose reduction or modification or anti-nausea medications, however, something to bear in mind in clinic when this does occur. Unlike that, in the imlunestrant program, we've seen some low-grade diarrhea. Again, these are single episodes of low-grade nausea, which are predominantly grade 1 or grade 1 diarrhea, and some fatigue. No high-grade toxicities. We haven't seen any ocular or bradycardia events with imlunestrant, which is what we've seen with camizestrant. We don't see any GI toxicities very predominantly with camizestrant. We do see some very low-grade photopsia and bradycardia with cami. And then with giredestrant, we've been able to see some fatigue, which is again low-grade, and some bradycardia, which is low-grade, and much lower at the currently evaluated dose of 30 milligrams, which is in phase 3 trials. Now, why is the toxicity profile so important? It is really, really important because of adherence, especially if we're going to start utilizing these drugs, say in the first line metastatic setting, where patients would stay on this therapy for a long time. And more importantly, as we're evaluating them in the early stage setting, where they would stay on this therapy for a long period of time. And we know that adherence translates into what we can achieve with outcomes. And so, really maximizing the benefit to improving adherence or persistence and figuring out a way of intervening for further improvement has been a focus with the development of these drugs. And how could we do that? There are a variety of measures to improve adherence. There are therapy-related interventions one can look for, which is educating our patients, providing patient-tailored prescriptions, and managing and identifying the adverse events in a timely way and intervening in a timely way, and certainly patient-related interventions where it comes to readdressing treatment misconceptions or remote monitoring tools or utilizing conventional and digital tools to educate our patients for managing these side effects and maintaining them on treatment. With that, I'd like to thank you for your attention.
Thank you for listening. Remember to download the practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, METAvivor. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/AQV860.